Hi, everyone. Welcome. My name is Shayna Casper. I'm the Executive Director of T1 International. We're really grateful you could join us for the launch of our 2024 out-of-pocket expenses and rationing survey of insulin and diabetes supplies. Today, we're going to be sharing some key insights into our latest global data and hear from advocates and authors who made this report possible. So before we dive in, please stay muted unless you're speaking. Use the chat for any questions or comments. If anyone wants, Allison here is on the chat who can answer questions as we're going. We're also going to have some time for questions and answers at the end, so please put in questions as we're going. This webinar is being recorded, and we will share the recording and the report after. So as we get started at T1 International, we believe in a world where everyone with diabetes, no matter where they live, has everything they need to survive and achieve their dreams. And we work to make that happen by giving communities the tools they need to stand up for their rights so that insulin and diabetes supplies becomes a reality for all. And we don't take any funding from pharma to align with our value of being truly independent in order to take bold and meaningful action. And action is desperately needed. Almost 10 million people living with type 1 diabetes across the globe. Half of those who need insulin to survive can't get it because it's unaffordable, inaccessible, or both. And high insulin costs and lack of access have led to rationing, which can cause consequential health impacts. We have also known for years that these impact poor people disproportionately. Our 2024 report is based on data from 55 countries, and it highlights some stark global inequalities and the devastating reality that where you live often determines whether you can afford to stay alive. We're going to drop the report link in the chat if you'd like to follow along, but today we're going to go over some of this data with members of our authorship team to share insights on the report, country-specific findings, and lived experience that puts these numbers into perspective. This year's out-of-pocket cost survey builds on data that we've been collecting since 2016, with updated questions tailored to what's most urgent today. So our 2020 and 2022 reports were peer-reviewed and published in scientific journals. And this year, over 1,000 people from 55 countries responded. And the data is just really scary. What we saw were the worst levels of insulin rationing yet. Many people are paying extremely high out-of-pocket costs, and the data shows that governments and health systems are still failing to meet the needs of people with diabetes. So our survey design involved multiple languages, careful translation. Josh from Analysis Group, myself, and other people with type 1 diabetes developed this research plan with ethical oversight and pilot testing. And after removing inconsistent and otherwise irrelevant responses, we analyzed 747 valid responses, calculating per person cost by adjusting for household size and income. And we used means and medians for a fuller picture. But now I'm going to hand it over to Chris, T1 International's Global Advocacy Manager, to talk through some of the major cost findings.
Thanks, Shayna. Sorry, I was having trouble with unmute. Hi, everyone. Like Shayna said, I'm Chris Taves. I'm the Global Advocacy Manager at T1 International, and I'm also someone who's lived with type 1 diabetes for nearly 12 years. And so I'm going to start with costs. I'll start going over our results. That includes cost data, rationing data, budgeting adjustments, and access. So our data shows that global average monthly costs for insulin and glucose monitoring is almost $300 or 11.77% of income. That's about 5% on insulin and 7% on glucose self-monitoring supplies. But when we break that down by country income levels, the inequality is even more clear. High-income countries, almost 9% of income is spent on insulin and glucose self-monitoring supplies. In upper middle countries, almost 33%, and lower middle and low income, it's almost 64%. T1 International's Fight for Five campaign calls for no more than 5% of income spent on insulin and monitoring supplies. The average today is more than double that, almost 12%. And the median is even higher at 30%. This discrepancy between the average and the median is particularly telling. It suggests a skewed distribution where a smaller number of respondents may be spending relatively low percentages, pulling the average down, while a much larger portion of survey respondents are experiencing far higher costs. By reporting the median, we highlight the more typical experience of our survey respondents, and this is especially important in global health data where income inequality and health system disparities can mask the struggles of those hit hardest by out-of-pocket expenses. So we had 11 countries where we had enough data to independently report. A note in Nigeria, people are spending over 150% of their income. In fact, over 19% of respondents total spent more than 100% of their per person household income on insulin and glucose self-monitoring supplies. This goes without saying, but we absolutely cannot stand for even one paying this much. It's just so vulnerable. And many were likely to take a larger than their per capita amount of their total household income for survival. Others were also likely relying on support from people outside their households, borrowing from non-household members, or borrowing from institutions. In Canada, the only country where people spent less than 5%, which is our goal for our Fight for Five campaign, and in the US and Panama, we actually had enough data to dig in on some of those results. So in Panama, people are spending over $338 per month on average, but this is not evenly distributed. Low-income households are spending almost 70% of their income compared to about 43% in high-income households. In the US, the average monthly cost is over $4,000, almost 6%, sorry, $400, almost 6% of income. But low-income Americans are spending almost 25% compared to just 2% for wealthier individuals. Even Medicare beneficiaries, who are supposed to have a $35 per month insulin cap, reported paying an average of $206 per month. Now I'll pass it over to Sarah in Brazil to talk about what this means in terms of rationing.
Thank you, Chris. Hello, everyone. I'm Sara. I'm a regional advocacy consultant for T1 International, and I'm based in Brazil. The high costs that Chris mentioned are forcing people to ration, which leads to such devastating consequences. Our survey shows that, as our survey shows, as you can see in this chart, looking at the columns on the left, 37% of people rationed insulin in the past year, 55% rationed glucose monitoring supplies, and 58% rationed one or both, which is impressive of a number as it is outrageous. In low and middle income countries, as you can see in the bar on the right, these numbers are especially high. About 54% of people rationed insulin at some point in the last year. About 19% rationed insulin at least once in the last month. Another 20% rationed insulin multiple times per month. And this is 2 to 4 times the rate of rationing seen in high-income countries. We see a similar picture in glucose self-monitoring supplies. 71% of people in low-income countries or lower middle-income countries rationed them at some point in the last year, compared to 53% in high-income countries. So because we have been doing this survey for some time, this is our 5th survey, we can track trends over time. In 2018, 18% of people reported insulin rationing. By 2024, it has doubled to 37%. Rationing of glucose monitoring supplies went from 33% to over 55%. Even as awareness of the crisis grows, access is getting worse. This situation is unsustainable and is frankly revolting. I will now turn over to Pilar in Panama to discuss how families are adjusting their budgets in response to this crisis.
Thank you, Sara. My name is Pilar, and I am the daughter, sister, as well as the parent of 2 children with type 1 diabetes. I moved to Panama 8 years ago, and the reason why I founded Diabetes Latam in 2020 was to provide, in Spanish, education and support to people living with type 1 diabetes and their families in Panama and other Latin American countries as well. We also advocate strongly. We currently have 1,800 members registered in our charity and provide care and donations to almost 300 families in Panama and education and support to people in over 15 Spanish-speaking countries. I advocate not only for my family, but also for the millions of people who do not have a voice to express how challenging their life is, living with a condition they did not choose to have, especially when they cannot afford essential insulin and self-monitoring supplies, crucial to stay alive. What I'm going to report is both heartbreaking and what drives me and the organization I lead to continue advocating. Over 70% of all respondents reported having adjusted their household budget to afford insulin. They reported minor and major budgeting adjustments, which means they must go without other necessities or simply cannot afford their insulin or glucose self-monitoring supplies. 80% of respondents had to do so to afford glucose self-monitoring supplies. When combined, 82% of respondents indicated they had to make budgeting adjustments to afford their insulin or supplies, underscoring just how widespread the financial burden of diabetes is. The data also shows a clear correlation between a respondent's country income classification and the likelihood of making these budgeting adjustments. In high-income countries, 74% of respondents reported adjusting their budgets to afford insulin or self-monitoring supplies. That figure rises sharply in middle-income and low-income countries, where almost 93% of respondents reported making budgeting sacrifices, indicating both greater cost burden and fewer economic safety nets. Our 2024 survey included new questions about systematic barriers to access, and what we found was striking. Even when insulin and self-monitoring supplies are theoretically available and affordable, or included in medical policy, people still face significant access issues. Barriers include, but are not limited to, 1, inventory shortages, 2, difficulty in obtaining prescriptions, 3, lack of nearby pharmacies, and 4, long travel times for care. The data highlights that nearly 69% of respondents reported difficulty accessing insulin. More than 70% had trouble getting glucose monitoring supplies, and almost 80% had difficulty accessing one or both. And this isn't just in low or middle income countries. 67% of respondents in high-income countries had trouble accessing insulin compared to 71% in low and middle-income countries. Overall, 77% of respondents in high-income countries versus 83% in middle-income and low-income countries face these challenges. This shows how access problems are widespread, and they're logistical, bureaucratic, and systematic, not just financial. To close out on our findings section, I'll hand it over to Maham in Pakistan.
Thank you, Pilar. My name is Maham. I'm a doctor, a co-lead of our 5 for 5 working group, and someone who lives with type 1 diabetes. Let's talk about what counts as affordable. In 2024, the WHO released a new affordability metric. According to their data, insulin and glucose self-monitoring supplies is affordable if your country's poverty line plus diabetes costs is still less than the salary of the lowest paid government worker. But we found that this metric can miss the mark. For example, according to the WHO framework, insulin in Colombia is more affordable than in Canada, shown by the lightest blue color in the left two sections. But our survey data tells a different story. Canadians are spending 4.4% of their income on insulin and supplies. Colombians are spending over 19%. We checked our work by looking at the International Diabetes Federation Atlas for per capita spending for people with diabetes. It is an imperfect metric, but useful for comparing our real-world survey data. And the IDF Atlas also shows that Colombia is nearly twice as unaffordable as Canada. This shows how relying solely on national metrics or proxies can dangerously misrepresent affordability. People are classified as having access while spending a huge percentage of their income to stay alive. Let's look at these measures all together. Many countries have costs under 1 for the affordability index, shown by the lighter blue under the purple line, meaning that the WHO would consider them affordable. But countries spending less than 5% of their income on insulin and glucose self-monitoring supplies, the darkest blue on the right of each section, those under the green line are rare. Let's look at Guatemala. The data shows that their insulin and glucose self-monitoring supplies would have been affordable under the Diabetes Atlas from the International Diabetes Federation data, but people were spending 79% of their income on insulin and testing supplies. Or India, which has affordable insulin and glucose self-monitoring supplies, according to data from the International Diabetes Federation Atlas, but our data showed that people were spending on average 40.2% of their income. To truly measure access, we must center real-world patient-reported data and define affordability as no more than 5% of a person's income. Now, I'll hand it over to Chris to reflect on what we couldn't capture and what research still needs to be done. Thank you.
Thanks, Maham. Again, I'm Chris, T1 International's Global Advocacy Manager. And so we want to wrap up all this data by saying something clearly. This data is powerful, but it's not perfect. There are some limitations that include the digital divide. Many participants needed internet access to respond. Language, we were only able to offer the survey in 5 languages. Self-selection, respondents were more likely to be digitally connected. Scope, we didn't capture costs like lab work, syringes, or emergencies. And country income classification. The WHO and World Bank designations don't actually reflect inequality that's within countries. Still, our results closely matched the International Diabetes Federation's Diabetes Atlas estimates, which reassures us that the numbers reflect real conditions. And this data is more real, coming from patients. And so there are future research needs, and some of those including in the survey people with all types of diabetes, not just type 1, collecting more qualitative, emotional, and relational data, a breakdown of findings by gender, age, and insulin type, expanding the survey translations so that we can include more languages and reach more people, and study long-term health conditions and outcomes of insulin rationing. But even with what we know today, there are proven solutions. So we're going to take a look at what's working, and we've just covered the data and what needs improvement. And so now we're going to talk about policy solutions and real-life examples of what is working to improve access and affordability. So I'm going to hand it over to Nicole.
Thanks, Chris. My name is Nicole Smith-Holt, and I am the T1 International's ambassador. And I'm going to share a bit about what has been working in the United States. As everyone on this call knows, the United States has really horribly high insulin and testing supplies for out-of-pocket costs, but also has a long history of taking action. In 2017, my son, Alex Smith, died after rationing his insulin due to its unaffordable price. I wanted to make sure that nothing like this could happen again. So I worked with the Minnesota Insulin for All chapter and state legislators to pass the Alex Smith Insulin Affordability Act in 2020. The law established Minnesota's Insulin Safety Net program, which includes an urgent need program that provides a 30-day supply of insulin for no more than $35 to those in crisis, and a continuing need program to help eligible patients afford insulin for up to 12 months. It got a bunch of legal challenges from the pharmaceutical companies, but it does stand as a powerful example of community-led policy change making a life-saving difference. While over half of the US states have now passed insulin copay cap laws, these caps typically only apply to state-regulated insurance plans, impacting just 1 in 5 people. That means more people, including those on federally regulated plans, employer-sponsored plans, or people who didn't have insurance like Alec, still face unimaginable costs. Our research shows that these laws work, but also that copay caps are also just a limited solution. They reduce out-of-pocket expenses for some, but do not lower the overall cost of the price of insulin. That's why national action is urgently needed. We need a federal insulin price cap that applies to everybody, including those without insurance or those in an emergency situation. A nationwide policy is necessary to ensure no one is forced to ration insulin ever again. I'll now hand it back over to Pilar to share about what they've done in Panama.
Thank you, Nicole. In Panama, the organization I lead, Diabetes Latam, partnered with the Ministry of Health in 2023. We signed an MOU and have developed a collaborative relationship which has benefited Panamanians in need by 1, strengthening communication and therefore trust between patients and the public health care system. 2, creating direct ties between our advocacy program, patients, and the government. And 3, simplifying the import process of donated insulin and testing supplies. These keep 300 families afloat. This has in turn created a more consistent supply, fewer bureaucratic delays, and a blueprint that could work in other countries too. I'll now hand it over back to Sarah to share about what happened in Brazil.
Thank you, Pilar. Hi again, I'm Sara. I'm T1 International's regional advocacy consultant based in Brazil, and I'll present a case study we did about Brazil and public pharma. The government in Brazil negotiated lower prices for newer insulins, and these are now available through our public health system for free and at point of care. The Brazilian government also is investing in local insulin production, which reduces dependency on multinationals and stabilizes supply. So why this matters? It is a strong public health system, and political will leads to real, sustainable, and affordable access. We also did a case study looking at what's happening in South Africa, where the government is suing the insulin manufacturers for anti-competitive practices, which keeps insulin expensive and out of reach. In South Africa, human insulin pens were discontinued, leaving people with no other choice than moving over to vials and syringes. From our survey, we learned that 44% of people rationed insulin and over 55% of people had difficulty accessing insulin last year due to this discontinuation. There were huge protests. That's why the South African government is investigating major insulin manufacturers for potential anti-competitive practices such as price fixing. If successful, it could improve access to affordable insulin in South Africa for patients, set a global precedent for legal action, and push for greater transparency and affordability in the pharmaceutical industry. I will now hand over to Maham to share about what's happening in Pakistan.
Thank you, Sarah. Again, my name is Maham. I'm a doctor and co-leading the Fight for Five campaign. Our research shows that over 71% of people had difficulty accessing insulin last year. In response to increasing scarcity and the cost of insulin from multinational manufacturers, Pakistan has taken a significant step forward with the local production of human insulin, marked by the launch of a new product in August 2024. This milestone follows coordinated advocacy efforts led by Meeti Zindagi, which convened key stakeholders during the March Global Day of Action Insulin for All Roundtable. While public pharmaceutical production remains a long-term goal, domestic manufacturing offers a critical pathway to reduce reliance on costly imports and address ongoing supply shortages. Building on this momentum, the Punjab government announced the Chief Minister Insulin for All program, which will deliver insulin directly to children with type 1 diabetes in 3 major districts of Punjab. The program draws on Meeti Zindagi's successful promise of insulin home delivery model and reflects a growing recognition of community-driven advocacy in shaping public health solutions. With local production underway and government commitment growing, this case exemplifies how grassroots leadership can drive systemic change to improve insulin access. I'll hand it back to Shayna to close us out. Thank you.
Thanks, Maham, and thank you, Pilar and Nicole and Sarah, everyone for all of their work in making this happen. So we've just thrown a ton of numbers, data, graphs, stories at you all here. It's been a lot. And it's really heavy. You know, as a person living with type 1 diabetes, it feels really, really scary. And it feels pretty affirming as well. Like there's all these news headlines and pharma's public relations saying in newspapers all over the globe, the insulin price crisis is over. And this data shows that the insulin price crisis is not over. For many, it's getting worse. So all of this data and research makes clear that patients know what we need. We're the ones leading the fight to ensure that everyone has access to these essential medications and supplies. So we need you with us. We cannot just let this data sit on a shelf. You know, that's why we're asking you to take action with us. So first of all, download and share the report. So we need I hope this really underscores how we need urgent global and national policy reforms. So we hope you can help us use this data to inform policymakers, public health agencies, inform other advocates in your country to call for community-led action on affordable, equitable, and quality diabetes care for all. This data is critical to get out there, not just for patients, you know, like me, to feel like we're not alone, but also, you know, for the media to cover this with policymakers. So please share this report, share this information widely. We're also going to be sharing the data from this report on social media over the next 10 days. So please do share and engage with this content to amplify it on social media. We're at T1 International on all platforms. So this report exists because of the tireless and tenacious work by people living with diabetes and those who love them. And as many people in this room know, T1 International does not take any funding from pharmaceutical or device manufacturers, nor from any company or anyone who might sway our work. And this research is not backed by any designated grants or specific foundation funding. Rather, this work was made possible by the generosity of our incredible community, individual donors who believe in the power of advocacy and people over profit. So just want to say thank you for making that happen. And that being said, we would love to secure some designated funding to do this vital work in 2026 to publish again in 2027. So if you or any funders with whom you work may be interested in supporting this research, we would love to connect. Please also donate to support this work. Again, we rely on donations from individuals, people with diabetes who spend, on average, globally, over almost $300 on insulin and testing supplies every month just to survive. So what can you give to help support reversing that reality? And finally, join the movement. We want to ask you to join us. So join your local Insulin for All chapter or partner organization. I'm seeing some Insulin for All chapter leaders on this call. It's amazing. Or join T1 International by joining our next advocacy network, New Advocate Speakers Bureau. We'll also put that link in the chat right now. But I hope that everyone here can take action in one of these ways. I just finally want to close by with a few quick shout outs and thank yous. First of all, thank you so much to the over 1,000 people who courageously and vulnerably took action by taking the survey. We wouldn't have this data without you, so thank you. And huge thank you to the many volunteers who made this happen. Our volunteer translators who got the outreach information in the survey, and then the survey results available in Arabic and French and Spanish and Swahili, as well as in English. To the organizations and clinics who shared the information with their community. This authorship team didn't want to be thanked, but I'm going to thank them anyway. So yeah, Chris, Sarah, Maham, Pilar, Campbell on the call today, also Liz and Katrina and Yvonne who had prior commitments. And special thanks to Josh Weinstein and the analysis group for the survey development and analysis support. So this initiative was conceived by T1 International's founder, Elizabeth Feaster, 10 years ago. And I also want to thank the efforts that it took on these former iterations of this report that was done in previous years, not only by Liz and Katarina, who are authors this year, but also by Katie and Rav, who reviewed this, and then also by Abhishek and Axel and Hanna and James and Radula and just many, 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 many more people. So thank you all. Again, this report is a labor of love, and we just want to thank all the people for donating their time and their efforts that we can create political change to stop spending hundreds of dollars each month just to stay alive. So that's what we've got for our presentation. I'm going to put up the next slide, which has the link to the survey as well as an email for any other questions. But I'm going to take these slides down in just a minute and want to see if anyone on this call has any questions for us to address now. So again, we know everyone's muted, but if you want to take a moment and put some questions in the chat, I'll just hold on a minute in case there's any questions right now. And seeing none. Oh, I'm seeing a question from Chris. Is there anything else that can be done with this data? Pilar, can I hand it? I see you're unmuted. Can I hand this question over to you? How can people use this data?
I think I've said it repeatedly, but in Panama, it's my lethal weapon. Everywhere I go, I just have these bullet points in my mind where I drop percentages, numbers, which are very impactful. So I use it for presentations to the board, to the Ministry of Health, to patients. I think we can use it in so many ways on social media posts. It's data that we seldom have, and I think it's extremely powerful. I just wait, I drag the previous surveys, I just drag them as long as I can, reporting, and now that we have fresh data, I add them to presentations, to conversations, to our website, to our social media. I find it one of the most powerful advocating tools.
Thanks so much, Pilar. Chris, can I hand this next question over to you from Julia? Given the note on internet access, do you think that there's a possibility that the affordability crisis is even worse in low-income countries? Oh, I think you need support unmuting here.
Yeah, definitely. Yeah, I think internet access is such a hard bird like hurdle that we have within this survey because yeah, I think it definitely doesn't show enough of what everyone's going through, especially in low income countries. And a lot of our a lot of our respondents or a lot of the partners that I work with as the global advocacy manager are coming from these countries and, constantly fighting just like we do and trying to get more visibility on things. And so if we were able to, open up like paper versions of the survey and have those be collected by one person, I'm sure that the results would be a lot more stark and even more tragic than they already are, unfortunately.
All right, I'm not seeing any other questions here. We will share this recording and the report out to all of the registrants in just a few minutes here. And I know there's some reporters on the call as well. If anyone would like to do further follow-up interviews for sharing this data out more publicly, contacting any of the authors on this report, please let us know. And yeah, everyone let us know if you have any questions. Hope you can use this data widely in your advocacy. Thank you so much. Yeah, let us know if you have any other questions, but I'll close this out. Thank you.
Thank you. Bye-bye.